This is a podcast on anesthesiology keyword topics, ENT, ear, nose, and throat, and eyes. This is part of the University of Kentucky Department of Anesthesiology didactic curriculum. The keywords from 2010 to 2016 on the topic ENT and eye are shown here. Under ENT, you can see there were questions related to laryngeal innervation and injury to the recurrent laryngeal nerve, laser airway fires and how to prevent them, thyroidectomy and some complications, including perioperative hypocalcemia, recurrent laryngeal nerve injury, jet ventilations and some complications of jet ventilation, and obstructive sleep apnea. Under the eye topics, postoperative blindness, including ischemic optic neuropathy, some of the things that we do in the perioperative period that increase or decrease interocular pressure, the ocular cardiac reflex, its afferent pathway and anatomy, the fact that sulfur hexafluoride gas, when put in the back of the eye after retinal detachment surgery, if nitrous oxide is administered, can expand that gas bubble and get us into problems, and some of the differences between retrobulbar and peribulbar blocks, which are used in ophthalmologic surgery. Let's start with airway innervation. Cranial nerve number 5 innervates the nose and nasopharynx, and it's represented by the light blue color on the bottom right. Cranial nerve number 9 innervates the tongue, oral pharynx, and the upper epiglottis, and needs to be blocked if you want the gag reflex to go away. Cranial nerve number 10, or the vagus nerve, divides into the superior laryngeal nerve and the recurrent laryngeal nerve. Innervation from cranial nerve number 10 is represented by pink on the bottom right. Superior laryngeal nerve, the internal branch, as represented up at the very top right, is shown piercing the thyrohyoid membrane and going internally and supplying sensation to the upper part of the vocal cords. The external branch of the superior laryngeal nerve is motor to the cricothyroid, the one muscle that's not supplied by the recurrent laryngeal nerve. And that cricothyroid muscle is a tensor, tightener of the vocal cords. If you want to do a superior laryngeal nerve block, you can perform it at the thyrohyoid membrane bilaterally. Recurrent laryngeal nerve is sensory below the glottis, and the trachea is innervated by the recurrent laryngeal nerve. All of the muscles of the vocal cords, laryngeal apparatus, are supplied by the recurrent laryngeal nerve, except that tensor, the cricothyroid, which is supplied by the external branch of the superior laryngeal nerve. If we want to block the distribution of the recurrent laryngeal nerve, it is often done by a transcricothyroid injection of local anesthetic. Patient coughs and spreads it up and down in their airway and gets the distribution of the recurrent laryngeal nerve. If that nerve is damaged bilaterally, the vocal cords can end up in a midline position and bilaterally adducted and cause acute obstruction and may require emergent tracheostomy. Let's look at the laryngeal anatomy in more detail now. Reminder that the recurrent laryngeal nerve supplies all the muscles of the larynx except the cricothyroid, which was supplied by that external branch of the superior laryngeal nerve and was a tensor of the vocal cords. Abduction, shown on the bottom right picture here, is movement of the vocal cords away from each other, and that's accomplished with the posterior cricoarytenoid. So if we look at the picture on the far right and see where the posterior cricoarytenoid, the little blue arrow, is pointing to, that muscle, when it contracts, utilizes the cartilaginous structure of the larynx and pulls those little vocal cords open into an abducted position. Adduction, or moving the vocal cords together, is a lateral cricoarytenoid function. Those muscles are supplied again by the recurrent laryngeal nerve. If you look at the vocal cords in the midline position in the epiglottis superiorly, inferiorly you can see the arytenoids, and on each side of the vocal cords is the piriform fossa or piriform sinus. Putting an NG tube down, a TE probe, or even an endotracheal tube sometimes, if it's off midline, can result in being stuck in this piriform fossa. Some complications of thyroidectomy is the next topic, nerve damage being one of those. If superior laryngeal nerve is damaged, you can end up with a weak voice and decreased pitch and what's been called a whispery voice. Remember that the cricothyroid, that tensor of the vocal cords, is the one muscle innervated by the superior laryngeal nerve external branch. If that nerve is injured, a weak voice or whispery voice can occur. Recurrent laryngeal nerve is the one that's most worried about, and you can lose the ability to pull the vocal cords apart, and they can be adducted midline position, paramedian position with possible airway obstruction. If you look at the top right and you see initially respiration and phonation in a patient without paralysis, you can see during respiration the vocal cords come apart. During phonation they vibrate in the midline position here. And with unilateral paralysis, one is midline and the other is paramedian. And with bilateral paralysis, during respiration, they're stuck in that paramedian position and can cause partial obstruction. One of the ways to attempt to avoid injury to the recurrent laryngeal nerve is monitoring with EMG. And there's special tubes, such as the one shown on the bottom right here graphically, that can be placed, very large diameter tubes with a little portion of it that ends up between the vocal cords with a stimulating probe that is connected to what the surgeon is dissecting with, and can be used to check the integrity of that nerve. In other words, if you're dissecting away and all of a sudden you get near the nerve and stimulate it, the vocal cords will contract together and you can get an alarm that goes off. So if you're going to monitor EMG during thyroidectomy, obviously you're not going to use rocuronium, vecuronium, but succinylcholine potentially could be used to intubate, allow it to wear off, and then check the tube's function after that. You're going to use that large tube to assure contact with the vocal cords, and you're not going to put a lidocaine jelly, for example, on it, or spray up the vocal cords, or use a laryngeal tracheal anesthesia in these patients because you don't want that denervated. Parathyroid injury can occur after thyroidectomy. As they're dissecting in the thyroid, those little rice-sized parathyroids, the 4 of them, can be either denervated or removed accidentally, and acute hypocalcemia, hypoparathyroidism can occur approximately 1 day to 2 days afterwards. The presentation of hypoparathyroidism or hypocalcemia is initially often tingling of the lips and fingertips. Sometimes there can be laryngeal stridor or laryngeal spasm, carpal pedal spasm if you blow up a blood pressure cuff on someone's arm, their hand contracts, classically called Trizot's sign. Facial contracture can occur if you tap on the 7th cranial nerve and the orbicularis oculi contracts. That's called Schell's sign. And on electrocardiogram, if you're hypocalcemic, QT prolongation is one of the things that can be seen. Intravenous calcium can be used to treat the acute hypocalcemia from the parathyroid injury, and airway management, including CPAP, non-invasive airway management, or endotracheal intubation may be needed. If thyroid surgery occurs and a big bleed occurs in the neck that impacts the airway, emergently the incision may need to be opened, the hematoma removed, and the airway allowed to become back to a midline and the patient be able to breathe normally. If you find a patient with a neck hematoma, it's wise to consider, if needed, awake intubation rather than giving induction drugs or relaxants. Taking away their spontaneous ventilation is a bad idea. Next topic is lasers and airway fire. To decrease the risk of a laser-generated airway fire, there's several things that we can do. One is reduce the flammability of the endotracheal tube, and on the top right is shown a flexible stainless steel endotracheal tube, which is very resistant to laser fire. On the one on the top right, you can see an endotracheal tube with dual cuffs, and one cuff can be inflated, one cuff can be left down. If it is blown by the laser, the other one could be inflated. Sometimes methylene blue can be put into the cuffs, filled the cuffs that is, and if a laser hits it, the blue dye can be distributed in the airway and you would know that the laser had hit the cuff. Saline is often used to soak gauze and put in the airway to prevent fire. PVC tubes can be used, but they're flammable, less so than red rubber or silicone endotracheal tubes, however. So it's that flexible stainless steel which is important. Or get the tube totally out of the airway, such as an apneic technique where laser is done without any tube going through the vocal cords, for example, for laryngeal papillomas or laryngeal cancers. Get the FiO2 down so the oxidant level is reduced. FiO2 should be less than 30%, heading towards room air. Helium or nitrogen can be mixed in. Remove the flammable material from the airway. As mentioned, if you can take the endotracheal tube out and laser without any tube in there, that's called apneic technique, or jet ventilation can actually be used during it. Less chance of laser airway fire. In the ASA Practice Advisory published in 2013 on airway fires, if you get an airway fire, immediately without waiting, these are the recommendations. Remove the tracheal tube and stop the flow of airway gases. Then flood the surgical field with saline. Reestablish ventilation, usually with mask ventilation, possibly followed by intubation and bronchoscopy. If there's pieces of endotracheal tube in the airway, remove those with bronchoscopy. Common laser types and risks. Carbon dioxide laser, the energy from such is absorbed by tissue water. It doesn't penetrate very deeply, causes a superficial injury, and we can protect ourselves from it by simply putting clear goggles on, and it's the cornea that would be damaged if you didn't have goggles on and you happen to get carbon dioxide laser fire near your eye. While the YAG laser penetrates deeper and can cause a deeper injury to your eye, including the retina, and tinted goggles are often needed. The YAG lasers are frequently used for debulking of tumors in the airway, coagulating tumors in the airway, and removing obstructing airway tumors. So the thoracic surgeon and pulmonologists are often the ones that are using this YAG laser. The next topic is obstructive sleep apnea, OSA, versus obesity hypoventilation syndrome, or OHS, mainly focusing on obstructive sleep apnea. OSA, up where the little star is in blue, you can see that the males are the ones that have it more, that may be associated with obesity. Risk seems to increase with obesity. While they're awake, there's a normal ventilation pattern, normal CO2, normal oxygen level, but at nighttime, the patient with obstructive sleep apnea has choking or gasping during sleep, often witnessed by the person that sleeps with them, and says, boy, they snore and awaken and startle all night long. If you do a polysomnography exam on them, a sleep study, they'll have greater than 5 obstructive breathing events per hour of sleep. And the stop-bang questionnaire is often used in preoperative evaluation if you suspect OSA in a patient. Stop-bang stands for the S for snoring, the T for tiredness, the O for observe to stop breathing while they're sleeping, and the P for high blood pressure. The BANG stands for the BMI being greater than 35, obese patients, older patients, the A, neck circumference being the N, and the G being for the male gender. The difference between OSA and OHS, you can see that under OHS, the two little blue arrows, that the PCO2 and the PaO2 are increased at nighttime while they're sleeping. Obesity hypoventilation syndrome, they hypoventilate. So their CO2 goes up above 45, for example, and they may have hypoxic episodes in the night where they don't awaken, don't startle, so they don't have the recurrent awakenings from sleep. The chronic hypoxia and hypercarbia can result in pulmonary hypertension, and the documentation of increased PaCO2 during sleep to above 10 millimeters from their awake supine values is one of the things that's used to make the diagnosis. Now, some miscellaneous ENT topics. First is jet ventilation. And at the top right, you can see a little jet ventilator being used in suspension laryngoscopy being done. During airway surgery, jet ventilation can be used. And as oxygen is jetted in, oxygenation can be quite effectively done, but ventilation, that is, the buildup of CO2, can occur because of hypoventilation. There's also some rare risks of pneumomediastinum and pneumothorax. Carotid sinus reflex when they're dissecting around the neck. Classically, this is with carotid endarterectomy, but a neck dissection can also result in it where pressure is put on the carotid sinus via the glossopharyngeal or ninth cranial nerve. The afferent input from that carotid sinus goes to the brainstem, and then the efferent, being the vagus nerve, goes to the heart, resulting in bradycardia. Simply stopping pressing on the carotid sinus makes this bradycardia go away. Nitrous oxide you're going to avoid in middle ear surgery, and if they're putting tympanic grafts on a patient, as nitrous oxide can increase middle ear pressures and potentially displace the tympanic graft. If someone has a Lefort 2 or 3 fracture, for example, a Lefort 1, we usually think of a mid-face fracture where the mandible, the nares and the eyes are not so much involved, but the upper jaw has a fracture, and then as you go up higher, up into the nares, and then up in fractures, including the eyes, and totally loose mid-face, Lefort 2s and 3s, you can have association with basilar skull fractures, dural tears, and if you blindly put a nasal tube in those patients, it may end up going through the cribriform plate. Blind nasal intubation is contraindicated with Lefort 2 and 3 fractures. Let's change gears now and talk about eye pharmacology. Intravenous agents and inhaled agents classically decrease intraocular pressure. The exception is ketamine, which can cause nystagmus and blepharospasm, which results in increased intraocular pressure. Nitrous oxide, if a sulfur hexafluoride bubble has been used for retina surgery, for example, to help that retina be displaced back on after it's detached, and you use nitrous oxide, that SF6 bubble can expand and raise intraocular pressure. Avoid nitrous oxide for 4 to 6 weeks after sulfur hexafluoride gas use. Some more pharmacology topics related to the eye. Succinylcholine can increase intraocular pressure, and it does so transiently for minutes, and not very high, but it does increase intraocular pressure. In patients with acute angle closure glaucoma, if you give them atropine or scopolamine, an anticholinergic agent can cause mydriasis, pupillary dilation. And I like to think of the iris basically like a curtain folding back against the sides of the eye and blocking the canal Schell, which is the drainage system of the eye, and the eyeball pressure builds up in those patients. So atropine and scopolamine in a patient with angle closure glaucoma can worsen it and cause a rise in intraocular pressure. Medications that are given topically, dropped in the eyeball, can be absorbed. One of those is ecothiophyte, which is used for patients with glaucoma. Ecothiophyte irreversibly inhibits pseudocholinesterase. So think of someone receiving ecothiophyte almost like a patient with a Dibucane number of 20, that if you give them succinylcholine, they're going to have a very prolonged and unpredictable effect from the succinylcholine, prolonged neuromuscular blockade. Phenylephrine does what it does when it's given intravenously, when it's absorbed topically, and vasoconstricts through its alpha-1 effects, increasing blood pressure. Beta blockers absorbed from the eye can cause bradycardia. Nonspecific beta blockers can cause bronchospasm. And Diamox, a medication that is used in patients with glaucoma, inhibits carbonic anhydrase, resulting in bicarbonaturia, that is, loss of bicarbonate in your urine. If you lose bicarbonate in your urine, you're going to develop a metabolic acidosis. Diamox is also used not only for glaucoma, but in our respiratory lectures, it was talked about as a prophylactic medication before altitude, going to altitude, for example, mountain climbing. It helps you start hyperventilating, which is a acclimatization response to altitude. Now, some postoperative ocular complications. One, corneal abrasion. If you don't tape the eye shut properly, or there's rubbing of the eye, like with your stethoscope as you're intubating. I've seen that happen sometimes. The patient wakes up in the recovery room with often unilateral eye pain, severe, with tearing, and lights bother them, photophobia, and if they blink, it hurts. That's the patient that with a fluorescein stain, as shown at the top right, often done by an ophthalmologist. You'll see little abrasions of the cornea, often simply putting antibiotic on that eye and taping it shut for 24 hours. The cornea grows very rapidly and repairs itself. Central retinal artery occlusion is frequently in patients who have had head and neck surgery, who are prone with pressure on the eyeball, and they wake up with a proptotic eyeball, hyphema, lid bruising, edematous retina, and this classic cherry red spot shown on the bottom right picture here. They've lost retinal artery blood flow, maybe from an emboli, for example, or a thrombus in the retinal artery. Cortical blindness, classically often after coronary artery bypass graft surgery, where a patient's been on cardiopulmonary bypass and maybe been hypotensive with low flows for an extended period of time, and the watershed areas of the brain, the occipital areas, don't get enough blood flow and they end up bilaterally blind. But if you look in the back of their eye, their optic disc will be okay and their pupillary response will be okay. We previously touched on acute angle closure glaucoma, and drugs that dilate the eye can block the canal of Schlemm outflow. The eyeball looks dead, and if you take a patient, for example, who has glaucoma, angle closure glaucoma, give them atropine or scopolamine, and then in the recovery room they have this blurred vision, you've used a mydriatic or dilating drug, the eyeball looks dead and distended, that's acute angle closure glaucoma. But perioperative blindness, number one cause after spine surgery in patients in the prone position is ischemic optic neuropathy, which can present unilaterally or bilaterally as blindness. It's painless. Remember that corneal abrasion was painful. And with ischemic optic neuropathy, it can be of the anterior variant or the posterior variant. The optic nerve comes in the back of the eye, and if the anterior portion of it, the portion that we can see when we look oftentimes in the back of the eyeball, is involved, the optic disc can be involved and have optic disc edema. And that's what I'm trying to show in the picture on the far right, is a pale optic disc edema with adjacent retina infarct, chalky white pale swollen and hyperemic optic disc. These are the clinical features of ischemic optic neuropathy of the anterior variant, which a fundal exam may be able to show some issues or problems in that patient. While posterior ischemic optic neuropathy, the optic disc may appear normal, but is the ION, ischemic optic neuropathy, which is the number one cause of blindness after spine surgery in the prone position. So again, the risk factors other than the spine procedures in the prone position is long general anesthetic, large blood loss. The male patients that are obese are the classically at-risk ones for ION. ASA Practice Advisory advises several things. Use colloids with your crystalloids to maintain intravascular volume. There is no specific transfusion threshold, with the worry that if your hemoglobin gets too low, we probably should be transfusing a patient, and maybe that might be a reason that worsens ischemic optic neuropathy, not enough hemoglobin carrying oxygen to that nerve, but there is no specific transfusion threshold. Check the neck position, the head position. Avoid having the head down below the heart where the eyeball could be engorged and put it at risk for this ischemic optic neuropathy. The next topic is just intraocular pressure in general, normally being about 10 to 22 millimeters of mercury. I suspect many of you may have had your intraocular pressure tested with a little puff of air oftentimes in your eye as a screen. In the perioperative period, there's things that we do that can either decrease intraocular pressure or increase intraocular pressure. The things that decrease intraocular pressure are our intravenous anesthetics and our inhaled anesthetics, almost all of them with the exception being ketamine. Hyperventilation and dropping the CO2 can decrease intraocular pressure. Patient being a little cool, decreasing the mean arterial pressure in the CVP. I like to think of that eye, if it's not engorged with blood, either from high blood pressure or high CVP, and hyperventilation, which drops CO2 and results usually in reduced blood flow and vasoconstriction of blood vessels, the eye pressures go down. Now, things that increase intraocular pressure, succinylcholine we previously mentioned, it does so even without the classic fasciculations that occur with sucks. If we defasciculate someone with, for example, a small dose of rocuronium beforehand, you can still get that increase in intraocular pressure. Studies done many years ago showed that if you took the muscles off the eyeball of a cat, for example, who's anesthetized, and you administer succinylcholine, they still can get the increase in intraocular pressure. and probably the mechanism is an increase in choroidal blood flow, or blood flow to the eye, as that mechanism of IOP increase. Ketamine can do it, raising intraocular pressure, but if a patient coughs or vomits or valsalvas, you mismanage an airway and put a tube down while they're light and they buck, intraocular pressure can increase dramatically, up in 30, 40 or more millimeters of mercury. Some physiologic things like letting your CO2 build up, or the patient get hypoxemic, or their CVP high, or their blood pressure high, also increase intraocular pressure. Now there's a reflex called the oculocardiac reflex that is important in the fact that if traction on the extraocular muscles is done, for example, by an ophthalmologist, maybe during strabismus surgery, and maybe pulling on the medial rectus muscle, all those things together would be classic for causing bradydysrhythmias. Heart rate slows, patient gets hypotensive, may even have asystole, and you tell them, please stop traction on the extraocular muscles. They do so, and the heart rate comes back up. That ocular cardiac reflex is a trigeminal, 5th, vagal, 10th cranial nerve, with the afferent limb being the 5th cranial nerve to the brainstem and back to the heart via the vagus nerve. So 5-10 reflex. That 5-10 reflex that is instigated oftentimes by traction on the extraocular muscles, or possibly by just pressure on the eyeball, or even manipulation of the globe, like putting a retrobulbar block in, which you think would block that reflex. But injection of the local can raise the pressure in there and cause it. All of those things can result in the OCR, or ocular cardiac reflex, 5-10 reflex. If they're light, if they're hypoxic, if they're hypercarbic, that aggravates that reflex. The reflex itself fatigues easily, which means that if you keep pulling on their eyeball and relax, keep pulling on their eyeball and relax, over time it tends to be reduced in the amount of bradycardia that it causes. This is not necessarily prevented by giving prophylactic anticholinergic agents to patients before surgery. And if this ocular cardiac reflex occurs, you tell the surgeon to stop manipulating, and they're still bradycardic, hypotensive. Atropine can be given intravenously, not intramuscularly, to treat the bradycardia. Remove the stimulus, deepen the anesthesia, give the atropine as previously mentioned, and even putting local infiltration of the extraocular muscles can reduce this reflex. At the top right, it's shown graphically the eyeball muscles as they're manipulated. You have the ciliary ganglion, the trigeminal nerve, the Gasserian ganglion, to the brainstem, back out through the vagus nerve, to the heart, SA and AV node, which the parasympathetics innervate, and bradycardia occurs. The last topic is retrobulbar versus peribulbar block. A retrobulbar block is when the needle goes deep into the back of the eyeball and penetrates the extraocular muscle cone. This is shown in the top right graphic. The needle initially goes in below the eyeball, is often redirected then up after it passes the axis of the eyeball, and goes back towards the cone of the eye and piercing the extraocular muscle. When it pierces that extraocular muscle cone, oftentimes you see a little tugging on the eyeball because it's pulling that muscle. Some of the complications of retrobulbar block is you can actually pierce the nerve or perforate the globe and drop it like a beach ball. Retrobulbar hemorrhage if you hit a blood vessel. And the ocular cardiac reflex from the injection and the volume they inject, as well as pulling on the muscles of the eyeball, that bradycardia that previously discussed can occur. One of the unique things about eyeball blocks is this apnea that can occur after injection of very small amounts of local anesthetic. We're talking, 2 to 6 cc's in the back of the eyeball that can spread along the optic nerve sheath here all the way back to the brainstem. So basically it's brainstem anesthesia, and patients can be apneic, severely hypotensive, dilated pupils, and if you just simply give them positive pressure ventilation, support their blood pressure within a very short period of time, this problem will go away. They'll start breathing on their own, and their brainstem won't be anesthetized by that local anesthetic for very long. The retrobulbar block is often combined with a 7th nerve block, because if you have a patient awake and you don't want them to squint and squeeze the eyeball, their orbicularis can be blocked by that 7th nerve block. Peribulbar is shown on the bottom right with the needle not going so far back into the eye. And you can see peri or around the eye doesn't penetrate the extraocular muscle cone. It's very superficial, and then therefore there's potentially less chance of a retrobulbar bleed or an optic nerve injury. However, you have to inject more local anesthetic usually, and it takes longer for the onset of the block. This ends our discussion of ENT keywords and eye keywords, and I hope that you have an excellent day. Thank you for listening.